The next panel we're going to have is something that when Dr. Kapoor and I were discussing what to have on this panel, this was something that was definitely on top of both of our minds. We see a lot of patients that come in treatment that are in this intersection of chronic pain and substance use disorder because they really go hand in hand. See so many patients coming in with pain, right, needing medications or people that are medication that started from chronic pain. So we have an amazing panel here for you. Um, our moderator is Dr. Soteri Polidoro. He is our medical director for addiction services at Northwell. Javier Jimenez, director of consultation liaison and chronic pain at Long Island Jewish, and Dr. Marie O'Brien, director of integrative care and pain management at Northwell Health Mather Hospital. Thank you so much, and I give the floor to you.
Great, thank you, Dr. Hakimi. It's a really great and pleasure to be able to participate in this conversation, and just want to reflect for a moment on really the wonderful conversations that have happened already this morning. Really starting with Diana and Kenny, and moving to really thinking about all of our patients in a very comprehensive way. And then, really just most recently with Dr. Hakimi's wonderful presentation on kind of emerging concerns around substance use. And so we'll be talking about another really important aspect of care, and that is kind of this crossroad of pain with substance use disorders, right? How do we think about it? How do we understand it? What can we do about it? And so I want to kind of first, as we get started, say thank you to everyone that's presented so far and been part of this conversation, as well as a huge thank you to the entire Wellbridge team for hosting this discussion and welcoming everyone so wonderfully, and ourselves certainly included. So as we talk a little bit about our own backgrounds and our own clinical experiences, Javier and Marie, would you mind talking a little bit about your own kind of path potentially to the care that you provide and the type of clinical services that you're actively engaged in? Because all of us have many different hats that we wear. And I'll certainly say that providing direct care for patients is one that all of us value incredibly. So maybe Javier, would you mind starting off?
Sure. You can hear me? Great. Hi, everyone. And I just want to echo very briefly the gratitude and the humility that I experience being here. This is an amazing facility and amazing experience. And thank you for the invitation to speak. So as mentioned, I'm the director of consultation liaison psychiatry, which is medical psychiatry, as well as chronic pain over at Long Island Jewish Medical Center, part of Northwell. The trajectory that got me to this point, actually very, very similar to the earlier position that we were hearing from. I was actually on track to become something very heroic, like a surgeon, a transplant surgeon or something like that. And then I had my psych rotation and I fell in love with that. And furthermore, within psychiatry, fell in love with medical psychiatry for the same reasons that were cited earlier, because we can kind of do many things in parallel. And so for years, specialized in medical psychiatry. I did a fellowship in that, but later when I was at the Cleveland Clinic for some years, and I actually got pulled into a very interesting patient population, which was chronic pain, specifically chronic disabling pain with a number of comorbidities, psychiatric, mental health comorbidities, as well as addiction. And I was invited to work in a unique department, not dissimilar from what is occurring here. It was actually a day program, not an inpatient facility, but a day program that fused medical care, psychiatric care, pain management, but also psychology, physical therapy, OT, et cetera, holistic therapies. And it was really a rewarding experience. And I was medical director of that and became pain medicine certified, et cetera. Also addiction medicine certified in that space. And 5 years ago, came to Northwell. And in my current role, I manage the medical psychiatry operations, but also carve out specific chronic pain / addiction consults that I see. And we have kind of an ad hoc addiction consult service in the medical floors. But also I have a clinic where I see an ambulatory space where I see patients with chronic pain, particularly ones who are not going to respond linearly to the next injection, the next stem cell therapy, the next device. They might have already tried that. They might have had a few too many spinal surgeries, et cetera. And at that point, we're actually thinking differently about their chronic pain. A number of paths have gotten me here, and I love what I do, but that's in a nutshell what I do clinically today.
Awesome, thank you. So I am very fortunate to be here with all of you today and to be able to share what is truly a passion of mine as well as my amazing team out at Mather Hospital. We are a nurse practitioner-led integrative pain management service, which is, I think, probably a little bit different than what you may see at many of the Northwell facilities and across the country. North Shore LIJ has a similar program. We are so fortunate, though, that because early on, when we started seeing the challenge of caring for people with opioid medication only or only pharmacologic approaches to pain, we quickly realized that that was not enough. And we are very grateful for a lot of the guidelines that actually support the care that we are so passionate about, which includes non-pharmacologic interventions and the role of the nurse or advanced practice providers to support individuals who are suffering with pain. So we are in a hospital setting, and we care for patients ranging from surgical pain, sickle cell pain, chronic low back pain exacerbated coming to the hospital. And then because we are not fortunate to have an addiction medicine specialty in our hospital, when there is a patient who is suffering with pain and substance use disorder, or perhaps patients who are on medications for opioid use disorder, and there's maybe a lot of confusion or chaos around how to approach these patients, we are the closest thing, so to speak, to the addiction medicine service. So we're called in quite often, and it's our toolbox of non-pharmacologic interventions that really drive the work that we do.
So really incredible clinical experience and clinical insight, and certainly for an issue and a challenge that is incredibly common and compounded by substance use disorders. There are, estimates that roughly 1 out of 4 of our patients who are initially diagnosed with a substance use disorder have chronic pain. And that's on the low end, right? For our patients who suffer with an opioid use disorder, it's closer to about half. So, we see this in all different environments. And can we start to better understand some of the kind of principles in understanding pain, understanding chronic pain versus acute pain, the type of pain from trauma, from physical trauma, as compared to neuropathic pain, right? Not all pain is the same. Javier, can I ask you, what might you suggest in terms of a way of thinking about pain, both comprehensively, but understanding all these differences as well?
Yeah, it's a great point, and I think actually that's where we need to start, because not all pain is the same. And we probably don't have enough time to do a robust treatment of the topic, but briefly, the way that I organize it, and I try to instill this in other colleagues who may not be pain medicine experienced, et cetera, or trainees, and even patients, I talk to them about this, is first, you really want to understand temporally what are you dealing with, right? A lot of our medical instincts are to think, well, is this neuropathic versus this versus that? And that's very important. We'll get to that. Nociceptive, et cetera. But it's really important to differentiate acute from chronic pain. Very different phenomena in terms of what is happening biologically, psychologically, and socially. I won't emphasize too much on acute pain, but with chronic pain, very briefly, we know that a number of processes take a foot and kind of potentiate over time: central sensitization, changes in the central nervous system, hyperalgesia, allodynia, all this jargon, all of these findings that we know biologically occur. Psychologically, we also see unfortunate ramifications of this. Living with chronic pain is obviously not a walk in the park. Huge toll: depression, anxiety, insomnia, fear of the future. People's worlds get smaller, if you will, which gets into the social bucket. The social dimensions of chronic pain are debilitating as well. People will pejoritize individuals with chronic pain, automatically assume a number of things, might keep their distance from them. Patients with chronic pain keep their distance as well from others. So it becomes really this complex morass that isn't necessarily the case with acute pain. So I think it's very important to distance ourselves from lumping them all. In medical education, there is very little attention to chronic pain itself. A lot of what we do in chronic pain is an extrapolation from acute pain. You know, if we really take care of that nerve, or if we use an analgesic, all will be fine. Well, it's actually become a very complex syndrome over time. So I think the temporal nature is very important. And then we get into the qualities of, is this nociceptive, neuropathic, nociplastic, which is another classification, et cetera. And then get more into the specifics of the individual that you're working with. To add complexity, there's medical comorbidities. There are conditions that are acute on chronic. You mentioned sickle cell, for instance, is a classic one that's very difficult to approach. So it gets complex, but I think the first order of business is to differentiate acute and chronic by definition, and to understand that it's not just this sensorineural kind of phenomenon. You hurt because you had an operation or a surgery or a medical injury. It's much more complex than that. And just doing that, I think, is half the battle, because you open patients and families and other physicians' brains into thinking, okay, we got to do more than just analgesia, for instance.
Thank you, Javier, for just kind of outlining the complexity, right? And it's a complexity that I'm hearing, and as a physician, I'm thinking, oh my goodness, like that is a lot that we are thinking about, that we are aware of. Pain is different. How do we address it? And that's the conversation that we may have with, other physicians, other treatment team members. And I wonder, Marie, from your perspective, right? How do you think about translating that understanding to our patient, right? To the person that you're providing care to? What kind of principles do you have in mind? Can you talk a little bit about that conversation that you may have?
Absolutely. That is a great question and such a great perspective. To the core of that is the foundation and philosophy of pain neuroscience education. You know, we heard Kenny and Diane talk this morning about, not being able to have a relationship with their provider and being told, I'm the provider, you're the patient, this is what I'm giving you, this is my prescription, and do this or else you're non-compliant. And that is what so many of our patients hear, when really what they need to hear and truly understand is that there is a reason, especially with chronic pain, there's a reason that they have pain and, more importantly, suffering for such a long period of time. And it's that foundation of why pain is being perpetuated, what pain is, which is your fight or flight response working with the body, so that your body is telling your brain you're in danger. And when we utilize non-pharmacologic interventions, if they don't understand the connection between the fight or flight response, their sympathetic and parasympathetic nervous system, in a scaled down, non-clinical, so to speak, way, they're not going to buy in to the idea that something as simple as aromatherapy, guided imagery, mindful breathing, yoga, although non-pharm interventions that are at the foundation of every guideline for the management of chronic pain, they're just going to think they're being brushed off, and that we're trying to, give them, to escape giving them a medication. When in fact, if they truly understand the neuroscience, that we're trying to calm their nervous system and then have a positive impact on their overall level of comfort, then we can get their buy-in and at least have them try and then see for themselves that they themselves have the self-efficacy and the autonomy to make an impact on the function.
Thank you, Marie. That's wonderful. And I was struck just when you mentioned specifically the issue of buy-in, right? And that piece of that education. And, in thinking about how does pain overlap with substance use, right? And as we, for all of those in the audience that are, spend a lot of time thinking and providing care for substance use disorders, right? We're all familiar with the, 11 criteria, and we think about, a couple, 4 related to impulse control and the social impact and high risk use and the physiologic effects as well. And sometimes we kind of group that into kind of different ways as we think about a cognitive impact of a substance use disorder, or the behavioral impact, and then the physiologic impact. And right, there's overlap, right, that I'm hearing with pain. And a term that was, I think, a kind of a little bit more popular roughly 20 years ago, this concept of pseudo addiction. Right? This idea of some of what we see that we sometimes would diagnose or consider with a substance use disorder are very clear effects from a medication that may be prescribed, right? How we talk about and how we assess withdrawal symptoms, well, we know if somebody is prescribed opioids chronically, they will experience withdrawal. Taking that medication appropriately every single time, they will experience withdrawal if it's suddenly discontinued. In the same context, tolerance develops. We know this from many medications. It is a pharmacologic effect of the medication that, as providers, we may prescribe for patients. And so we also know that when pain is not being addressed, it is clearly incredibly distressing. And there is going to be behavioral impacts to it. And how does that evolve, over time? What may initially be more of a pseudo addiction, more driven by a goal of addressing pain, may evolve 6 months later, a year later, 2 years later, into an opiate use disorder, into another substance use disorder. And so there isn't this kind of clear, a person has pseudo addiction or a person has substance use disorder. It would be great if it was always clear, or if there was a checklist that we could review, but there is so much overlap. And in some ways, the system that we are all part of struggles with that. And there's tension there sometimes. And so as we think about treatments, maybe if we can go to the non-pharmacologic treatments first. I think a lot of us have kind of spent a lot of time thinking about what medications are prescribed, kind of so forth. And I wonder, Marie, maybe if you can speak a little bit more on those non-pharmacologic interventions that you utilize. And maybe just for everyone, if you can help us understand really what those interventions are, and what do you see in your patients that are engaged in those interventions?
Oh, that's a great question. And, it varies based on the person. So patients will always say to myself or a member of my team, what's the best non-medicine thing that I can do for myself? And just like anything, it's what you're going to use and what resonates with you. So just as if we have so many different medications in a certain category, there are many different non-pharmacologic interventions available to help with pain. These can range from something as simple as aromatherapy, which we use in the hospital. So we use a simple aromatherapy inhaler that the patient can keep at their bedside, keep in their pocket, and when they feel anxious or they need a way to tell their nervous system that they're safe, they can take this out. It's a tool they can use. We educate them to find just a moment or two to take a few slow, deep breaths. That again calms the nervous system, and that is part of pain, your nervous system in hyperdrive. And between utilizing that and the deep breaths and maybe some positive guided imagery, patients can experience a significant reduction in a sense of calm, a sense of comfort. It doesn't fix the reason that they're having pain, but it can help them with the suffering aspect of pain. And so that's something simple in the hospital. And then outside of that, things like acupuncture, even auricular ear seeds, which is something that we're trying to help move forward in our organization. But I think sometimes from a system approach, things that we don't understand, there are barriers go up. So there's barriers to acupuncture in the hospital. There's barriers to nurses doing something as simple as ear seeds or aromatherapy or clinical hypnosis. So I think in trying to support our patients, anything we can do to remove the barriers to things that can promote self-efficacy will go a long way in empowering our patients when they leave the hospital to have these tools.
I mean, so that's really helpful. And you know, so many times we see this challenge beyond prescribing a medication, right? We can prescribe medications, but the other services, the comprehensive care that we can really provide, that does have evidence supporting its use, how are we able to adapt to those models? Um, Javier, in terms of thinking about that distress that Marie mentioned, you know, these other factors that come into play when someone is experiencing pain day after day, month after month, the kind of impact that you may be called to assess, or to provide some care for. Can you help us just get a sense of that when we think comprehensively about a person, the behavioral impact that you tend to see, and maybe some thoughts about what kind of interventions do you know, kind of come to mind to you?
Yeah, it's a great point. First off, I want to say that we need to be able to, you know, walk and chew gum at the same time. We've got to do a lot of things with complex patients, whether it's this discussion or others, right? And so I think we need to try our best to help with the pain, of course, and not only focus on distress or psychobehavioral features, right? We got to do both. When individuals live with chronic pain for significant amounts of time, you know, months, years, they tend to have, you know, this has been validated through studies, they tend to have higher rates of catastrophizing and certain cognitive patterns, behavioral patterns like, you know, avoidance patterns, deconditioning that's physical, but also mental deconditioning in terms of less ability to really process stress. And so all of these factors come into play when I see somebody who's had chronic unrelenting pain. And to get to your question, I think about the totality of what I'm seeing. I'm seeing neurobiology that extends beyond where what part of the body is hurting, right? I sort of go beyond the peripheralist, that's my word that I use, perspective of the knee or the back or the belly or the ankle or whatever hurts, and think about the entirety of the pain neurocircuit, right? Once you start to really consider all of it, not just that thing that is hurting, but also the spinal cord, the brain, certain pathways that are coming back down from the brain, importantly, to modulate pain. When you really consider all of that and bring this to the patient's attention, which, by the way, is rarely part of their care, unfortunately, as medicine is built, then you start to really identify a number of targets. Some of them may be psychobehavioral, but some of them might be purely neurobiological. So an example, I see a number of patients who have been physically deconditioned, who really can't tolerate much pain over time. And I introduce the concept of their own endogenous pain relieving system. Goes by numerous names, the descending pain pathway, etc. I sometimes use cartoons to show them the anatomy. This can be very powerful. I explain that this is actually something that we should kind of work on. We should beef this thing up. It's inside of you. And for years, not to your fault, of course, nobody's really attended to that. So we need to calm the nervous system. We need to remove barriers that are clouding your sensorium. Unfortunately, some individuals are in polypharmacy. We need to think about physical reconditioning to activate those endorphins and enkephalins and everything. And other psychotherapeutic principles like mindfulness-based stress reduction and CBT to assist with beefing that part of you up. When it's couched in those medically validating terms, that there's a little part of your anatomy that I actually want to manipulate, it's very different than saying I only want to reduce your stress or I only want to adjust your depression, etc. This segues nicely into then, to answer the second part of your question, what are the interventions? Half the intervention is that education. But next is thinking about medications, assuming we're not using opioids for a second, which, by the way, is an assumption. We'll talk about that later. In some patients, they do need opioids. But assuming we're not, there's a whole host of non-opioid strategies that are, neuropathic agents, psychopharmacologic agents, alpha adrenergic agents. We heard the talk earlier about how sadly those are in adulterants, et cetera, plus, of course, the non-pharmacologic agents that Marie was referring to. So it's a complex dance, if you will. There's a method to the madness. If you do it enough, it starts to become actually quite effective and efficient. But I think it has to combine that neurobiology, the medical validation, education, and then some actual tangible strategies to offer to the patient with confidence, that I'm going to help you not just with your pain, but with your distress.
So I'm hearing so much similarity even in thinking about actively addressing substance use disorders. I don't know if everyone in the audience is kind of hearing this overlap of, the neurobiology, the comprehensive effects on the patient, how we are not only directing our care and our thoughts around risk benefits of medications and exposure and so forth, but patient education, right, as well. And that in many ways gets tied into a challenge that so many of our patients face, which is stigma. And so, I wonder, recognizing that there are, so many challenges that we probably all experience with this complex clinical challenge, is there a vision of an ideal integrated practice or an ideal way to collaborate with or for your patients who do have a substance use disorder? And how do you think about that, or what's been your experience?
There is such a lack of a program such as that. Just like we've seen with co-occurring mental health challenges and substance use disorder, there's an even greater dearth of resources available for patients who suffer from chronic pain and mental health disorders, or chronic pain and substance use disorder, and heaven forbid they have all three. Then there's really such a lack of resources. And often, from our experience, it comes down to this perception that maybe it's not a financially viable program, for patients, for us to care for people holistically who have chronic pain. So ideally, collaboration between mental health, addiction medicine, pain management, community-based holistic care practitioners that can help with the non-pharmacologic interventions, and having them accessible for our patients in a way that they feel like they are cared for. And, we're not just saying to them, it's either medications or nothing.
Yeah, I think it's an important question, but I agree, there's really not enough in this space for these triad, if you will, of problems: chronic pain, mental health needs, and substance use. 2 or 3 of those combined. But I will say that I had the distinct honor and pleasure of working in an interdisciplinary space that did that, the program I mentioned before at the Cleveland Clinic. And I think for operational reasons, financial reasons, there are very few of those around. It takes a Herculean kind of effort to get that kind of thing going and to maintain it. But I applaud, places like Wellbridge that clearly, I was even looking at the programming there, for instance, on the screen, try to emulate that. That interdisciplinary nature is not the same as multidisciplinary nature or community-based connect the dots care, which is really the standard of care. Multidisciplinary is better, but interdisciplinary is pretty rare. I think that's what's needed. And I think within the interdisciplinary care model, you need to be guided by a ton of education to sort of dispel stigma, misconceptions, all of that, a ton of validation. And that, I think, most importantly, needs to come from physicians or representatives of healthcare, as well as peers. The peer part is critical, in my opinion. And then thirdly is the actual clinical part of it. So notice the hierarchy that I just offered. This is my opinion, at least. education is king, validation is a sort of next second, and then the clinical care. The clinical care is critical. We need to obviously have clinical care that's state of the art and has multimodality to it. But I think the first two actually are half the battle.
I'll share some of my own clinical experience and sort of opportunities to partner, particularly with sometimes pain management, maybe from a little bit more of a perspective of a substance use disorder specialty program. And for patients who receive methadone in an opioid treatment program, the opportunity now to partner with inpatient programs, with inpatient services, and adapt care is, frankly speaking, so different now than really since the initiation of a licensed opiate treatment program in the early 70s. So, as many people may be familiar, just about a year ago, the entire kind of regulatory framework of opioid treatment programs, meaning attendance to receive methadone, was dramatically changed. And I'll just highlight, for the sake of time, two items. One is that near daily attendance for someone new to treatment is gone, right? So the ability to match what a person needs in terms of their treatment with a medication that is only one of two that has a very clear, direct impact in reducing fatal overdoses for someone with an opioid use disorder, as well as a host of other clinical improvements, has been changed for much more a decision on attendance to a program that may vary to once a week to once a month over just the first few weeks of care, dramatically different than daily attendance. The other major, in terms of partnership, is the ability for opioid treatment programs to be able to partner with any inpatient environment, to directly admit patients in a way that clinical practice had made it very difficult to provide a person who is newly identified with opioid use disorder or newly open to engaging in methadone treatment who may be in the hospital to be directly admitted to an opiate treatment program. And we have a few minutes. We definitely want to leave some time for questions, but I wonder if Marie, Javier, any kind of just initial thoughts on the other, let's at least touch on the FDA approved medications for opioid use disorder, right? Thoughts on managing your patients on buprenorphine, or thoughts on managing your patients on extended release naltrexone, and then we'll move to questions.
Awesome, of course. So in the hospital, just incident that we had, or an opportunity that we had maybe a few months ago, an individual who came into the hospital with a very painful condition, large, painful wound, abscess to the spine, needing hospital care for extended period of time, and also admitting to having substance use disorder and really wanting treatment, wanting methadone. And the initial reaction from, say, hospital medicine, who is not familiar, not comfortable with methadone and treatment for medications for opioid use disorder, was, that's not something we can start here. You need to wait until you're discharged. So for more than 2 days, this individual had to endure withdrawal, anxiety, very close to signing out of the hospital. I'm sure we've all experienced patients like that. And we were so fortunate to be called in right before the patient was going to sign out AMA, and we were able to navigate collaboration with experts from Northwell. I was able to, call a friend, receive guidance, and we were able to start this individual on methadone in the hospital, titrate the dose up, and we were able to allow this person to endure their treatment and then get connected with resources on discharge, which I think is so important.
I tend to not secure permission as right. I hope for forgiveness. So prior to any changes like this, I've you know played with the rules. I think that was mentioned earlier. You have to in this space, and have always advocated for whether it's methadone or Suboxone or naltrexone or whatever we're talking about, getting it done. That doesn't mean I have a 100% hit rate by any stretch, because I have to work with others and there's a lot of moving parts. But I agree that where there's a will, there's a way. It may be time consuming, it may require extra steps, but there are ways to uh, start methadone, to use your example, de novo in the medical hospital. Suboxone, make sure the person gets a script, make sure the person connects to the next step, or comes to my clinic where I might, bridge them until they get to another, long-term plan. So I think that problem solving, this is the probably less scientific part of this, is really critical. It's a case by case advocacy that has to happen, and I think we all should be unapologetic about it.
It's a wonderful perspective. Um, Questions from anyone? Yes.
Thank you. So I just want to say, first of all, I really liked how you used that phrase "walk and chewing gum" at the same time. I'm really going to try and work that into my professional language, like in my emails and meetings and
And
stuff
then
like
add a
that.
third thing in there, and now you're really juggling.
There you go. So, I have a really good working relationship with our CL team at my hospital, which is crazy that we ended up striking up a conversation during lunch.
Yeah.
And I was wondering if maybe you could expand a little more on, how you might approach that patient that I was kind of, talking to you about, right, like towards the end of lunch. If you want, I can, explain a little more.
Very briefly for the group, he was sharing that sadly an individual sustained a horrible injury and now is a double amputee, lower extremities, has been in the hospital for a month and not getting, correct me if I'm wrong, appropriate pain control.
Yeah, so they've been medicating him. They've been giving him opioids, and they had reached out to the addiction consult service because they were concerned that as we get closer to discharge, that there might be a concern for an opioid use disorder because he's had a history of substance use disorder in the past.
Yeah.
So they wanted us to,
Yeah.
yeah.
So a couple of reactions to that situation. Number one, I tend to be forgiving of primary teams who maybe don't know what they're saying or doing. Couched in there, I want to give them the benefit of the doubt that there's a good intent. They're watching out for the patient, don't want to cause another problem, all of that. But we could quickly say, gosh, these people are really not advocating proper pain, and they're stigmatizing him because of his addiction and all of that. So it can go both ways. But back to my original first question, this is acute pain. I hate to make it, terribly simple in that way, but it is. It's acute pain in somebody with a history of addiction, sure. But this is somebody who's had a terrible injury. It's 1 month fresh. The definition is at least 3 months to 6 months, right? And the qualities of the injury, double amputation, are really important to manage acutely because it can transition more so into chronic pain and greater risk for addiction and substance use if you don't do things now, like appropriate pain control. Phantom limb pain and all that other stuff can develop if at higher rates if you don't do something about it now. Furthermore, the argument about substance use raises in many minds this idea of risk, right? There's a greater risk of abuse. But also from a pain management standpoint, there may also be a pain threshold difference in that individual, right? Very likely, to your point about opioids and individuals who have pain. So it may be that we need to be more aggressive with this individual, right? But a lot of good intentioned, well-intentioned minds are out there thinking the opposite. We need to spare this person of risk of addiction. And yet maybe, every case is different, maybe the way to do that is actually with aggressive pain control now.
And I'll just add one small piece to this. It is sadly, I've received a number of calls where sometimes the team, again, concerned about how best to manage a person's pain who may be on methadone or buprenorphine, thinking that the methadone or the buprenorphine in which they're receiving for their opioid use disorder covers pain.
Yeah.
Right? Well, they're on methadone. They receive 120 milligrams a day. Therefore, they're good. They're already on pain medication. Similarly for buprenorphine. And just to say, without any question, that is not the case, right? We really need to consider pain and address pain when it's clinically indicated in every person that we manage. And that's something that's important. Do we have time for one more? So thank you, everyone. Great pleasure.
Thank you so much. For our panel, give it up for them. Thank you so much. This was amazing.